Hello, we are the Association for Child and Adolescent Mental Health, or ACAM for short.
I'm Dr. Amanda Maxwell, and with me my colleagues Tamsin and Osman and Malik.
Hi.
Tamsin and I are clinical psychologists, and Osman is a neuropsychiatrist. He's cycled down to join us because I think Sally was going to join us from our team, but she wasn't able to. So Osman's come along. So we're going to talk about tics and Tourette's today. And can I just get, because some faces I recognise, obviously, but who are people here from CAM services or from CAMS? Yeah? No? Education? From education? What are other people from?
I've got about half a hand for that.
Okay, half CAMS or half education or...
Half education, half health. We're speech and language therapists, but we do ASD work.
Oh, great. Okay. Just so we know who's working with who. Okay, great. So we are going to talk today on tics and Tourette's, and we work at Tandem, which is the specialist movements team. So it's a tic and neurodevelopmental movements team at the Evelina Children's. So obviously we see a lot of young people with tics and Tourette's. So I'm just going to go through a bit about background, because obviously people have different knowledge here, so I don't want to go too much into this because this can get a little bit dry, and I want to get onto some of the cases. And then also Tamsin's going to talk about treatment. So we've got some videos as well. If you have particular questions, I think we've got time at the end, but you can also stop me because we're quite a small group. So what are tics? They're involuntary abrupt movements or sounds that occur individually or bouts, so you can get a whole bout of them all at once. Usually you get a premonitory urge, so it's like a sense or a feeling in the body that precedes the tic. But if you're working with children, particularly littlies, a lot of them will say they don't get that. So, particularly 6 or 7-year-olds will not know what you're talking about. But as people get older, they tend to start recognising it. Tics are both suggestible and suppressible. So if you talk about them, see them, think about them, you're more likely to do them. But also, people can suppress them even for just a few seconds, and that goes all the way up to some people can suppress them the whole day they're at school. And then they range from simple tics to complex. So they're categorised, I'm not going to go too much into this, but basically into simple and complex, motor and vocal. And that's just some examples of simple and complex. I mean, it can get, the complex can get quite complex, as in there can be a whole series of movements, and particularly when it starts to be self-injurious, it can be quite concerning. So this is the DSM diagnosis. So provisional tic is if you have vocal or motor tics under a year, 3% prevalence. Chronic motor or vocal tic disorder, so that's where you have just motor or just vocal, and it lasts longer than a year. And that's about 1.6% of people. And then Tourette Syndrome is when you have multiple motors, so at least 2 or more, and 1 vocal lasting longer than a year. And actually, it's quite important, we find it quite important to let young people know what Tourette's is, because I think there's so much in the media that's not helpful. And we try to sort of say it's no different to tics, it's just tics, but it's just a different combination of tics.
Because the general sort of knowledge that people hold about tics is that if you swear, then that's Tourette's. So people consider Tourette's is equal to swearing, but the definition of Tourette's a minority of people, 8% or 10% will have coprolalia. But because television and the media portrays people as swearing, so they think that people with tics always swear, but particularly if you've got Tourette's, that means we just
try
a
to
bit of myth,
demystify it a bit, yeah.
So with Tourette's, do you have to have the vocal tic as well?
You must have one vocal. Yeah.
And with sniffing, is that?
Yeah. So.
What is vocal?
Yeah. Actually, that's a good point. I did separate them out before, but it's a good point, because I think people often think vocal is often like echolalia or coprolalia, but it can be like a cough.
Yeah.
So it can be any of those sounds. It doesn't have to be.
Throat clearing.
Yeah, throat clearing. It can be sometimes people will just make a sound like
Okay.
It doesn't have to be a word. In fact, the words or phrases are what we would consider complex, whereas the single syllables or a throat clearing would be like a simple tick. Yeah.
Or even a humming.
Yeah. Squeals are really common. And the other one that you get is that people will vary the tone or speed of their speech. So they might be talking, they suddenly go like that. So that would also be considered a tick. So you can get in speech variations.
Okay. Thank you.
I mean, just on the prevalence, there is some research to suggest that kids, that up to 20 to 30% will have just very brief episodes of tics at some point in their childhood. So to sort of let people know that it's not that uncommon for kids to experience just a brief tic, it's that prolonged or chronic is when it drops in terms of prevalence. So in terms of epidemiology, the mean onset is around 5 to 6. Many more males than females, about 3 to 1. And what you tend to get is the initial presentation is generally simple facial motor tics. So you might get a sort of eye blinking or a sniff or a sort of grimacing. And then as they progress in age, this is generally, obviously not everyone's like this, it tends to move down the body and get a bit more complex. And often I think a lot of our kids still have some of the blinking tics, even though it's sort of moved on to other tics. There's quite a strong genetic link, so you're 20 times more likely if you have a first degree relative, so it's very important to ask about relatives. In terms of the cause, there's a natural waxing and waning, so you will see them get better and worse within the day, within the week, within the month, which obviously has implications for treatment, because you think it's gone really well treatment and you realise actually it's just a natural flux of the tics. And the peak tends to be around 10 to 13, and I would say that's when we tend to get referrals to our clinic. So they may be either at initial diagnosis or when it's really flaring up. They tend to be exacerbated by, I would say, arousal generally, actually, not just anxiety and stress, but things like excitement. So when kids get really excited, they tend to get loads of tics. And they tend to be lessened by distractions or when you move your attention away from the body. So they're focusing on something else. It tends to reduce. So one of the things that we do is when young people come to our clinic is to do a bit of psychoeducation and talk about the course of tics, because a lot of what we do is actually not intervene and sit and just wait, so particularly if they're very mild, because in terms of who goes on to have tics, there's a significant proportion will only have mild tics or no tics at all, because it's neurodevelopmental. So as the brain develops, by sort of 18, late teens, there's a good proportion that will either not have tics or they're very mild or no longer a problem. There's only sort of 20% where it gets worse or it's particularly severe. So a lot of kids will grow out of it, basically, as a message we give families. And pure Tourette's is associated with better outcome, and we're going to come on and talk about comorbidities.
Amanda, are we going to have access to the slides?
I think so, yes. Yeah. Okay, I'm just going to talk very briefly about the neural basis of it, partly because I think it's important to understand the overlap with comorbidities. So the part of the areas implicated are the basal ganglia, and then this circuitry, so the CSTC circuitry, which is basically what links the basal ganglia with the cortex. And this same circuitry is also implicated in OCD, and the same regions are implicated in ADHD. And in terms of the neurochemistry, it's basically about too much dopamine and not enough GABA. I mean, I don't know how much you want me to go into that, and we have a neuropsychiatrist if you want to ask particular questions about that. But the reason it's important to know about this is because comorbidities are the rule rather than the exception. So 90%, well 80 to 90% of children with tics will present with a comorbidity. And I think increasingly there's a question about these boundaries, these diagnostic boundaries, how meaningful they are, because there's so much overlap. So there's quite a lot of research going on. In fact, we just went to a conference where there's a group, I think they're in the US, is Matthews in the US?
Yes.
Yeah. And they're looking at the genetic overlap between the different disorders. And basically what they're finding is there's huge overlap between ADHD, OCD and tics, but with particular symptoms. So the symmetry that you get, people have often talked about in terms of OCD, but an exactness and symmetry, things need to be just right, is actually far more associated with Tourette's than it is with OCD. So there's a question about should that be categorised in OCD at all, and probably it should be Tourette's. But because there's so much overlap, one of the things that they're suggesting is actually, is it a failure of top-down processes? So what they mean by that is because it's effectively a problem with inhibitory control, and that's what ADHD and OCD is. So it's difficulty with inhibiting control of behaviour or movements. And so is that the main issue or the sort of core problem, rather than breaking it up into different disorders? Does that make sense?
Can I ask you something? Where would you put ASD in that as well? Because often things like symmetry and uniqueness
Yeah.
seems to be the same as
So I think ASD would be considered a comorbidity, rather than some of these. I think there is a question: is it even a comorbidity, or is it part of the same?
But
Disorder.
you can draw a distinction. So if you break it down, so if you take it into that these are the common, let's say the ADHD is 50%, OCD or OCD is 40%. How common is ASD? And so I'm coming from that paradigm where you are separating these. So it's 5%, although there's one study that showed 25%, but usually the generally accepted is 5%. So ASD is much less common, pure ASD. But now within the phenomena, the need to organize and follow certain rules is generally much more pervasive in ASD and slightly different, because in the Tourette's it's much more what we call a compulsion. The organization isn't that it's more that you have it for very specific things. So you might be highly disorganized, your room's a mess, but you have this certain rule that when somebody touches me on this side, I get a sensation, I need to equalize that sensation. So either they need to touch me on the other side, or I need to touch myself, and then it's equal. Or if I step on a line, then I have to put my other foot on the line as well. So qualitatively, once you're working with people with ASD and tics, so the compulsions within tics, you can see that they're slightly different, and they're usually just compulsions, not necessarily intrusive, obsessional thoughts that if I don't step on the line, my mum will die. They just say it doesn't feel right, or I feel irritated till I've done it.
thoughts not attached.
Yes. So.
And actually,
yeah.
I think I've got a colleague that was at in the Maudsley OCD team, and she would say, Amanda, that's not OCD, because if there's no intrusive thought, it's not OCD, it's just a compulsion.
But that said, we do see a lot of children who, even though they might not meet the criteria for ASD, they do show a lot of the features of. So we see a lot of children who've got a strong sense of injustice.
And sensory sensitivities
lots of
and
sensory
cognitive
sensitivities.
rigidities. So then you do see kind of overlap. So I would say that yes, 5% proper ASD, but then you've got a range of young people with Tourette's who have other features, cognitive styles of ASD thinking. But I think that's not uncommon. All developmental disorders have such a huge overlap with each other.
And I think that's kind of where some of these researchers are going, because these constructs are sort of what we do to sometimes cancer commissioners like them, don't they? Because you then treat that in that service and that. But I think what they're saying is there's such an overlap. How meaningful is it? And actually, when you reduce it down to individual symptoms or presentations like threat of harm, like aggressive urges, some of those are overlapping enormously between ADHD and Tourette's, or between OCD and Tourette's. So it's a question of should we even be separating them out in the way that we are.
I suppose it matters on the therapy, doesn't it? Those what you decide to treat and how you decide to treat it, and the outcomes.
It does.
The clinical decisions you make.
Some of it does, although Tamsin will go on to talk about how we do intervene, because a lot of it, if you think about OCD and Tourette's, a lot of it is a very similar treatment, which is exposure and response prevention. But the reason I think it's important is because when we talk to kids that present with, like Osman was saying, where they have a whole host of difficulties that probably don't meet criteria for a diagnosis, but they're really struggling to manage their impulsivity, or they're struggling with different features, that we say actually, what I say, that it's one way that one group's talked about is a difficulty with their braking system, as in they've got leaky brakes and it doesn't quite work, and things get through, and sometimes it's movement, sometimes it's behaviour, and we need to help them with their leaky brakes. I just think it's a nice way of explaining it to kids.
It's like a disorder of a disorder of inhibition.
Yeah.
So it, inhibiting a movement, inhibiting a behaviour, impulse control. So it's like
sneaking through. Yeah. So in terms of the course, ADHD, I mean, it depends on the studies, but the comorbidity is around 50 to 90%. I mean, it's a massive range, it always annoys me, those ranges, but and OCD is more like about 30 to 50%, depending on the study. But you can see that you tend to get an earlier onset of the ADHD type presentation, then you get a tic onset, and then you get OCD, and that tends to be what you see. And they may all overlap, or they might have one or two of the others. Anxiety is also really prevalent in a lot of kids we see with Tourette's. And actually is often what we would intervene at first before the tics. Partly because anxiety can increase the severity of the tics. And it can be about a lot of things. It can be about what we've just been talking about, symmetry and evening up, and if they can't get it, they get really distressed. Sort of not getting that just right feeling. It can be social, so particularly as kids become more aware of their peers, people teasing them if they're getting bullied. And then there's also a panic presentation, which we've called tic attacks or tic-like attacks, where you get a tic, and then the person worries about the tic, and it kind of escalates very quickly to a whole sort of, it's almost like a bout or a tic attack, we call it, and it just is constant. And Sally, who's in our team, has kind of put it together in a paper actually as a sort of panic model. And we would treat it like a panic model, the tic attacks.
How common do you see kids, sort of older age group kids, to develop Tourette's or tics, who never had any Tourette's or tics at a younger age, but had perhaps anxiety? So
what
maybe
age?
15, 16.
Okay,
Very, very uncommon.
Yeah.
So usually one of the indicators of whether the tics is a functional movement, if somebody else in the family has, is the usual age of onset is 5 to 6, or let's expand it to 4 to 7. So if somebody really gives you history, because although when people often say for the first time I got my first tic at age 15, often they've had tics, but they haven't read. Once you give them loads and loads of examples, did you ever blink or blink, and they say, oh, actually yes, he had. But then you'll have a group who didn't even have that, and often no family history either.
And then we think, yeah.
So then you kind of think whether this is a functional movement or a tic-like movement that looks like a functional tremor, functional jerk-like move, things like that. So very unusual. Although people argue that there's an adult onset Tourette syndrome, but that's a controversial thing. There's not much scientific research evidence. So I think in day-to-day clinical practice, I would think of it as anxiety-related movement, functional movement, unless obviously they missed it completely and they had very minor tics, such as minor, and then something happened in their life. The anxiety is very high and it's coming out later on. Rare conditions would be massive head injury, use of high doses of amphetamines for recreational purposes. So then when you have unusual movement, so you have to have a reason for it. Without a reason, I would say...
Quite interesting, isn't it? Yeah. And then also development of further on tics on top of that. So they develop at a later age. I have a patient like that, so developed at a later age, and then it's kind of adding on one tic after the other, and they're kind of increasing in number.
And they often don't have suppressibility. They
they
don't have rostrocaudal. So usually, the blinking and sniffing. So you start like that, and then it progresses. So the functional ones might just say, "Well, it started with my hand," or some other, so more dramatic, less following a pattern. So there's you can sort of differentiate.
And I think that would be one of the main features, is if we see an adolescent present to our clinic with suddenly severe tics with no history, I think that we all start to feel alarm bells. And we are going to talk about functional tics. Right. So I've put rage attacks in here because actually this is probably one of the things that families say is the biggest problem. So and that they want help with. So a lot of kids that have tics or Tourette's will present with rage attacks where they sort of have this sudden explosive temper that's out of proportion, and it can cause enormous difficulties in the family. And actually, I mean, I don't think we go on to talk about that. Do you talk about that in treatment?
No, just tics treatment.
Yeah. So, and actually, the way that we would intervene would be the way you would intervene in any anger or rage issues in family, you know, with a child that you were seeing CAMS. So we don't do anything particularly specific with that, but that is often a reason they present.
So do you think that's emotional regulation difficulties as well?
Yeah, yeah. I mean, it's part. I think it's all part of that profile. It's not exactly linked completely to what we were talking about in terms of the circuitry, although it probably is to do with impulse control.
Yeah, because they have poor impulse control. So when something triggers their anger, they will just show it much more because they'll control it less. So they're inhibiting their anger less, just like they're inhibiting their movements less. So it's like part of that triad of they will have rage episodes because they're poor inhibitors, they're poor impulse control, just like they have ADHD and tics. It goes along. I suppose when we break it down, it sometimes gets difficult because there's a CAMS service or an ADHD service managing the child, and they also have, let's say, ODD and conduct difficulties, and then they have rage episodes. So everybody sort of says, well, their anger is more ADHD or more behavioral or more Tourette's, and then people argue which service should manage the behavior side. And if it's a looked after child, then it's even more complicated than who's going. But to be honest, they all, and it's very difficult to separate where is the rage. But one thing is clear that we do see a lot.
Yeah, we
of
do,
rage.
and in some ways, is it relevant where it belongs because. We would work with it in the same way, that they're finding it difficult to control and manage. There's impulse control, emotion regulation difficulties. We also see low mood and depression, particularly I think in young people that are worried about what other people think about their tics, or if they have a lot of pain from them and are struggling with them. I mean, one thing I would say with tics, and I don't think it's in here, is that the severity of the tic is not a good indicator of impairment. So a lot of the time we'll have people that come to clinic that have what we would consider quite mild tics but are incredibly impaired. So they're really suffering, their self-esteem's really affected, they're really struggling at school, everyone's very, very worried. And then we can have, I think sometimes boys actually, that are sort of going to secondary school, they've got a good group of friends that are not bothered at all. And they can have really severe tics and you think, oh gosh, that must be really impairing, and they're not bothered at all. And I think you've got to work with the impairment in the room, you know, if they're not worried. And there is a higher rate of suicidality, obviously for all the reasons mentioned. We often see also specific academic abilities or difficulties. Yeah, I'm not going to go too much into this because I'm kind of aware of the time we're halfway through. Some of the things that are problematic at school, because I know there's some people from school here, is that tics can interfere with tasks such as handwriting, particularly if you have motor tics around your hands. Another thing is that kids often really try to suppress their tics in the classroom, but of course if you're trying to really suppress your tics in the classroom, it means you're probably not attending to what's being taught because it takes a lot of effort. And a lot of the time kids are very worried about exams because it's quiet, they're under pressure, so their anxiety is very high and their tics just come out all over the place and everyone can hear or see. And for that reason, we often recommend they have it either in a separate room or they get extra time or both, because it's really impairing, and so they get these terrible grades and it's really tough. And then, you know, they're ticking and then worried the time's ticking down and they can't get it under control. Yeah, and then there's the impulse control. Oh. Oh, that's a bit hurtful. Why is that not working now? Sorry. I can't get that to move on now. Okay, so this is just a quote from the focus group from a parent. So basically saying that, you know, kids will have lots of different little tics that are not problematic, but obviously you get this sort of bout very impairing or problematic or painful ones that are concerning. And one thing that I've not mentioned is tics move around the body. So kids might present 1 week with, you know, a sort of eye blink, or that tends to be around a bit longer, but say a neck movement tic. And then the next week they'll come with a totally different tic. It's moved on. And often there's anxiety about them picking up tics, or that, you know, they got rid of that horrible coprolalia and that's back again. Okay. So I'm just going to quickly go through assessment so we can get onto a case. So things we think about is the onset, which we were talking about. When did it start? Because that can be a bit of a red flag if it's suddenly in adolescence. Severity, frequency, when's it been worse? One of the things we talk quite a lot about in clinic is what makes it worse or better, because that can be quite helpful when we think about treatment, because there will be things that make it worse. So, you know, some kids wait when I'm at school, when I'm tired, when I'm hot, playing computer games, they nearly always get worse, especially the facial tics. And in terms of the nature of the tic, we think about, are they suppressible, are they suggestible, and do they have an urge? And the reason we think about these is because it kind of indicates, is it a tic or is it something else? Which I'll talk about in a minute in terms of differential diagnosis. But of course, one of the things we do is watch in the session, are they ticking? But also remembering that they wax and wane. So sometimes kids will have terrible tics, they come into clinic and there's none. And you'll see in the letter from the referrer saying, oh, I didn't observe any. But of course, that doesn't mean that they're lying. It just means that on that day, maybe it's not particularly bad, or they're kind of really nervous and holding them in. But it is interesting to see, you know, if you're talking about the tic, do they tic loads more? Or can they hold it? Sometimes we do a sort of, okay, let's see if we can hold it for 10 seconds. Can you do it? How long can you hold it for?
And it's probably much better to observe, because often when you ask young people that, when we're talking about the tic, so if I do a tic in front of you, do you feel like doing it more? So you ask them about suggestibility and they will say no. But then you go like, and they'll go like that, and you go like, so suggestibility, you will see it actively in the session rather than actually asking them about. I think it's the older ones that will kind of know what suggestibility is and will say yes. Others will often just say no. Yeah. So don't entirely rely on that question about are they suggestible. Make your own judgment based on yes.
Yeah.
And premonitory urge in the same way, although you describe it, the younger ones, as you said, don't get. But sometimes they will, even if they feel it, they don't necessarily recognize. So when you later on ask the question about, can you suppress it, can you hold your tic, and they will say yes a little bit, and then you say, well, what happens when you hold a tic? And they say, oh, because it gets very painful. So they're referring to the urge often, but they've only felt it in the context of if they've tried to hold a tic, then the urge gets worse.
Yeah, and often that's how we try to elicit an urge, actually. So if they're saying we have no urges, we'll often say, okay, let's hold it, and they'll hold it and say, can you feel anything anywhere in your body? And then that's probably when they say, oh, actually, this feels funny here. Okay, and then obviously we ask about co-occurring difficulties or comorbidities, because these are by and large are probably the things that are more problematic than the tics. So things like OCD, OCB. So I think, because we've talked, as we were saying, about the symmetry, sameness. So we do see a lot more of that than the OCD that I think you generally see in CAMS. So in CAMS you see the checking the cleanliness, all that sort of thing. We don't see so much of that actually. We see far more about the symmetry, some of the threats of harm as well, or intrusive thoughts about harm. ADHD, I mean, once again, even if they don't meet threshold, I think we get loads of kids that kind of got the sub-threshold impulsivity, very jiggly, jittery, hyperactivity, anger and rage, although they'll often volunteer that as a major issue, anxiety, and then specific learning disabilities or difficulties. Just some specific things. Obviously you do your normal developmental history, but we do ask about tics and OCD in the family because there's such a strong genetic link, and particularly OCD in mothers. And actually, it's the same thing that what Osman was saying about the history. A lot of families say, no, there's none in the family. And then as you go through and you say, has anyone done, eye blinking? Oh, actually, do you know what? You do that. Or and they will have not labelled it, because a lot of people, 1 or 2 generations ago, it just wasn't diagnosed. So they've just known that Auntie Joan's always done that, but never known that was a tic. And then we do quite a lot of impact on functioning, because this is really about whether you intervene or not. So is it starting to impact on schooling, both academically but also whether they can participate, and also the family beliefs, how are they coping, are they struggling, but also beliefs about tics. So I think often we get people where they've, say in the family it has been known for generations, or they've come from other countries. There can be very different beliefs about tics. So some people have had diagnoses of epilepsy and been medicated for it. There can be a whole range of beliefs really about, you know, whether it's because of a trauma that's caused it, or loads of different
I think
ones.
there's especially interesting cases that where when the tics were starting age 4 to 5, and they had noticed something happened in the family, either the parents separated, or there was domestic violence, or a grandparent died, and there was a flare-up in tics. So the families automatically associate the tics were because of that psychosocial, and there's a lot of feeling of guilt and blame and all of that. Or the other group that we see is parents where they know sort of theoretically tics are harmless, than 80% chance you'll outgrow them or will have, but despite all of this sort of psychoeducation, they feel like, well, I want to do something to stop the tics. You tell them they're cosmetic, but they really want to work on something to just get rid of tics. So often kids who have seen private doctors or might have seen are on high doses of medications, and their tics are minor, and you speak to the child, I don't care, the tics are painless, they're not fussed about them, but the parents watch the child like a hawk, that's a new tic, and so they are actually reinforcing tics.
Keeps diaries of it, or,
Exactly.
you know, and because they're so suggestible, of course, all these things actually will increase the severity or frequency of the tic. So the very thing the parents think that they're doing to help, like massaging or, you know, helping them with all these bars, they're drawing attention to the tic, and it actually increases the severity. And there can be some very negative beliefs as well, you know, where children get into trouble, and I think in schools as well they get into a lot of trouble.
Eye-rolling tics, for instance, because you teach them something and it looks like you're being deliberately rude.
Or swear, if they're swearing.
Swearing.
And also I think one of the really difficult things is because tics are so suggestible, young people, if they have coprolalia or copropraxia or things like that, they are more likely to do offensive things when it's inappropriate. So it will seem like, you know, in a situation like I had a young person that whenever he walked past Jewish people would call out anti-Semitic comments. And of course, it just seems so inappropriate, and how could that possibly be a tic? I mean, it's just so contextual. And it's very, very hard for schools and families to work out, particularly if you have a child that's having rage attacks as well, what is behavioural and what is a tic. And sometimes we will sit down with them and go through the behaviours and the tics in sort of a list almost, because it's very hard, because you need to intervene if it's a behaviour in a very different way to a tic. A tic you kind of almost want to ignore. If it's a behaviour, well, obviously you've got to intervene as a parent and a school. And one good indicator is if it's a tic, often children will feel a bit embarrassed, and even though they might not say sorry, you can see them look down or look away, and it tends not to be a sort of build up into the same person and targeted in the same way. But it is tricky, I think, and I think it can be very complicated. And obviously the other thing that we consider is the impact on functioning. So how is the child, how are they coping?
It's almost like they get an urge to deliberately do the opposite. So for that, they have to have that awareness that this is inappropriate. But they will do those things to themselves. If something's hot, they will get an urge, I need to go and touch the hot oven. And then they just can't stop themselves, and they will touch the hot oven. And in the same way, going to the airport and just saying bomb. You know, or but it's often mostly about physical descriptions of others. But when they will often say, they will try to camouflage it, cover it up, or change the word, or put a hand over them. So that kind of shows the effort that they're making to inhibit themselves as well, at the same time as having such a strong urge, I just have to say something.
I mean, you mentioned about sort of the attention to it. Unfortunately, when they get into trouble for a tic in class repeatedly, even though the teachers know that this is a child with a diagnosis, and there's so much attention to it, you leave the class or just don't come back for today or something like that. And that kind of feels like, you know, A, it's a reprimand, B, it does bring on more tics. And,
Yeah, and actually,
particularly in that class,
yeah.
I find.
Yeah, no, absolutely. And a lot of what we do, I mean, we have a nurse, and one of their main roles is to liaise with schools to say, look, you know, they need to just be ignored when they're doing that. Or if it's really loud and disruptive, move them to a quieter place, but keep them involved. Or if it's really problematic, then they might go to a quiet space, continue working. We're always really clear that the tick should never mean that they are excluded or taken
Because
out of
of it,
Because in some ways it's a reinforcer, because if you hate maths and you tick loads and then you end up outside of maths. But also it shouldn't be a reason for exclusion, ever really. Yeah, so we were just talking about differential diagnosis. So what other things can it be? And functional movements is something we see quite a bit that presents in clinic, where it's not tics, it's functional. And it tends to present later, so it tends to be adolescent. And we would work with it quite differently, actually. And I think we've got some videos later, haven't we, of functional movements. But they do have a different feel to them. They will often say, oh no, I can't stop them at all. But interestingly, when you're in clinic, if you work very hard with a young person, you'll find distraction tends to work very well with functional movements. Yeah, but it can be very impairing, because they often present to A&E and often falling, dropping out of school and things, so they're quite problematic. Tick attacks are what we're talking about, where you get a tick and then you get a sort of a panic that associated with the tick. So either they're worried about what other people are going to think, or they're worried about hurting, or just a belief, oh no, here comes these ticks, I can't stop them, it escalates and escalates till it's a full-blown tick attack. I've put OCD in there just to be sure that there's not intrusive thoughts with it, that they're not doing compulsions. And also motor stereotypies. Are people familiar with those? Yeah.
I had someone recently who'd been given a diagnosis of tics, and actually I've never seen anything like it. It was just incredible. It turned out in the end he's in a real imaginary world.
Yeah.
And he was fighting and acting out all these things until you said him.
Oh wow.
You.
Oh, did you? Oh yeah. Yeah, it probably was us. Yeah.
Oh, you're going to love him.
Yeah. So we often get this is a misdiagnosis. So either they're told they've got motor stereotypies, or they're told they've got tics. And of course there's comorbidity. So there's about 20%, I think, isn't it? And motor stereotypies are typically associated with ASD. So they're the repetitive rhythmic movements. But you can get it in the typically developing population as well. I would say the main things that differentiate them is that motor stereotypies, particularly in younger kids, is they tend to be pleasurable. So as this lady was describing, sometimes you get imagery with it where they're in an imaginary world and they enjoy it, they don't want to stop, whereas tics is usually aversive and they do want to stop. However, they usually can stop very easily. So if mum or dad says, stop that or come out, they won't want to, they'll be annoyed, but they can stop it. Yeah, and the onset is much younger. So 80% of kids with motor stereotypies will present with them before 2. So that's a sort of key feature as well.
And they're more, so they don't wax and wane so much.
And they don't move around the body.
So if somebody's stereotypies are mostly hands, that tends to stay with hands and fingers. So much more of less movement. And if there's a decline or increase, it tends to be more gentle increase or gentle decrease rather than waxing and waning.
They tend to start to privatize them more, do them in private or on their own, particularly if they're quite socially aware. I mean, one thing I would say is that with motor stereotypies, as they get older, they can get a bit annoyed with them because it becomes a bit more compulsive. So it's not always that they, especially for older kids, they don't always enjoy them. But I think as a general rule, you'll find, especially littlies, they quite like it.
And the reason I suppose to differentiate between tics and stereotypies is that if somebody's doing stereotypies and you think they're tics and you entirely ignore them, sometimes the stereotypies keep on increasing. So tics you ignore. Stereotypies, yes, we do mostly ignore, but they can be interrupted, and especially if they're increasing, you can intervene to or discourage or encourage to privatize. Because if you entirely leave them and they really like them, then they will just keep doing more and more and more till they completely fill their free time with doing stereotypies,
they can spend
because
hours
they get
doing
addictive.
them.
Yes.
flapping and stuff.
Yeah.
Yeah.
And then other neurological conditions. I mean, I put that up there because I guess we have a neurologist in our team, and it can be obviously very helpful to make sure that it is a tic and not something else going on. And I think as a general rule, I mean, I'm a psychologist, I think I wouldn't feel comfortable if I saw an unusual tic making that call. I'd want to make sure a doctor has sort of seen them first and said that, you know, it's not something else going on.
I think especially if they only have one tic, then you kind of wonder if somebody's doing just one single movement, is this actually a tic? Or they have a head injury, or they have epilepsy, or they have several conditions going on at the same time, some sort of unusual tremor and tics. And the difficulties, the comorbidities are very common. So it's often not that it has to be one thing. You could have, so they do indeed have tics, but they have something else going on as well.
Yeah. I've just realised the time, so I'm going to quickly go through it. I've just put up some measures there that you can look at. I would say the top one is kind of the gold standard, which is what we use when children first come into clinic, and then there's some others that we would use. I would use, say, pre and post treatment. Do I have time for this case? Probably not. Do you want to do yours and then we can go back?
We could do that. What have we got till 7:30 and then time for questions? Or
Okay. Do you want? Shall I do this case? Because I guess we're asking questions throughout anyway, aren't we? Okay. I just wanted to present this case because this is a boy that presented with, and I'm really sorry, we don't actually have the videos of it because we've struggled to get them. We do have videos, but I can't get them. But he's interesting because he presented with 3 different movements. And part of our assessment, so I did a cognitive assessment and we did quite an extensive clinical assessment, was to try and differentiate what were the movements. And I think the neurologist was worried about whether there was something else as well, but I won't get too much into that. So this was a 12-year-old boy. Mum had a history of anxiety and quite a lot of checking behaviours. She didn't have OCD, but she definitely had obsessive-compulsive behaviours. The little boy had been diagnosed with epilepsy and had seizures from 0 to 8 years. But as we went into it, I think our neurologist was increasingly sceptical of whether they were true electrical seizures or whether they were non-epileptic, because they seemed to occur at times when he was worried about something, like just before a move, and I'm not sure she was terribly convinced they were epileptic in nature.
And there's a lack of evidence because it moved around the country, so the evidence that we were trying to gather
couldn't get any from the
hospital, so there
hospitals.
wasn't any conclusive diagnosis. They just told us, and
We had it in letters, but we didn't have any of the tests that had been done or anything. He'd always struggled through school with learning difficulties. When I did an assessment with him, his verbal IQ was 79, his performance was 92. So basically his non-verbal was much better than his verbal, and he had a profile really of dyslexia, so he really struggled with phonological decoding and reading. And he was bullied through primary school and then into secondary school, and by the time we saw him, he'd been withdrawn from school and was at home, sort of homeschooled, although not really. His presentation was that he had tics, so he had quite significant, neck and blinking and hitting tics, so he started to hit walls and things, and they gave him gloves. And he also had vocal tics. So the onset of the motor was 6, which is what I was saying, that you often get the motor to start with, and then he had vocal onset around 11. And that, they were quite loud. Then he also had what we thought was OCD. So he had fears about stabbing someone or harming himself. So in the video, he's chopping I don't know what it is, carrot or something. And you see him, I think he tics, but then he throws the knife down. And when we talked it through with him, he was saying that he had this thought, because he has tics, that he was going to stab someone. So he's worried about his tics, basically. But then he developed compulsions as a result.
And I think that's an important thing about tics, is that normally they do not interrupt an action. They can interfere with handwriting or something, but especially when there's dangerous things that can happen. For instance, you don't usually fall down. If you're falling down as a result of a tic, then it's usually functional. Similarly, if you've got a knife in your hand, even if you have a tic, you will get through. So because the knife would fly, and they were describing it as a tic, so we were already suspicious that usually you get through But it was interesting that he would get these thoughts very, very clearly, triggered by holding a knife or any other sharp
or being
object.
around a saucepan or
and
anything.
then the compulsion was,
that
I have to throw it.
Yeah. And then he would. And I mean, as a result, when he was at school, it meant that school was very worried. They weren't allowing him to participate in lots of things like home economic classes. They got worried about sports days. They weren't letting him do any PE. So he's becoming more and more excluded. And then he also had what we felt were probably more functional movements. So there's a video of him cycling along on his bike and then suddenly sort of falls off his bike. And he had no intrusive thoughts associated with it, although I think as it came out, he wondered about whether he might fall in the river. But he had no control over.
Which is close by the cycling track to the school. But I think it's linked with going to school. So he cycles to school. So you could formulate, is it linked with that? Or is it linked with the thought that the path that he's cycling on is next to a river? Although it's not next to a river. I think it might be like 20 meters away. But what it appears to be, if we cut that out, that when you look at the video, he's just cycling. It's not that he's having tics. Suddenly just gets off and just falls.
Yeah.
Not even gets off, as in it feels like something is happening to him, and a layperson would see that as, oh gosh, this is a seizure. Look, he's cycling and he has a seizure and he falls off, but it's not a seizure at all.
And also, what Osman was saying before, that one of the reasons we feel it as functional is that whenever we see kids that have tics, once they start exercising, doing sports, the tics go. I mean, you get anticipatory tics, so right before the action or right before the activity. But once they're actually doing the movement, you don't tend to get the tics. But he was definitely getting it during the movement. So the formulation that we sort of put together with them was to think about how the tic can impact on the cognition. So even though there's not cognition associated with tics, then you can get other movements or other behaviours associated with it. So he felt that his tics were dangerous. And so as a result, which he had masses of anxiety. I mean, there was a whole lot of family anxiety, but he himself had a lot of anxiety. And that fed into compulsions and into functional movements. And then, of course, what happens is then he's withdrawn from lots of situations. So withdraws from school, which he's struggling with anyway, and he's bullied at. And he withdraws from activities. And so it sort of reaffirms to him that actually his tics are quite dangerous because he's now sort of isolated, really, from all parts of his life.
So, moving on to thinking about how you might treat tics, I'm going to focus on tics themselves and focus on talking therapies. Now, there are medications as well, and I know that there are some psychiatrists here, so we've got Osman, if anyone's got any questions relating to those at the end. So perhaps the most helpful guide, really, in terms of how to treat is the European guidelines for Tourette Syndrome, which was produced in 2011 by the European Society for the Study of Tics, and it's kind of a review of the literature and then guidelines based on what the evidence is at the moment. And they came up with a very handy flowchart describing the stages of treatment and when to treat, starting with, no matter what the severity of the tics are, the psychoeducation, and as Amanda talked about earlier, that's talking about the cause of tics, the fact that actually it's best to ignore them if you can due to the suggestibility of tics. But then if tics are really bothering the person or impacting on their life, you would move on to think about offering some behavioural intervention. And the ones with the evidence base are exposure response prevention and habit reversal training. And I won't go into that fancy bit at the end, but basically it's talking about how many sessions and when you might use which one. But I'll talk about that a bit more as we go along. So I want to talk to you about both HRT and ERP, what they involve, what the treatment might look like. And they're both based on this book down here, which is called the CBIT Manual, a Comprehensive Behavioural Intervention for Tics. And many of you have probably heard of them in relation to other difficulties, so as Amanda was saying earlier, ERP for OCD. So habit reversal therapy targets each tic individually, and the course of treatment is around 12 sessions of 1 to 2 hours per week, with homework on a daily basis in between, because the key for these interventions is practice, and repetition, because you're learning a new skill and you're retraining your brain in a way. So the important bit is practicing in between, which is tough for children. So we encourage rewards for doing the home practice. So the course of treatment involves psychoeducation, some motivational work. Because it's quite an intensive treatment, actually you want to make sure the children and young people have got motivation to do it. So we try and tweak out for them how tics are impacting their life, how would your life be different if you didn't have tics, and build on any motivation they've got. We do relaxation as well, relaxation training, and then we think about tic awareness and the premonitory urge awareness. So to try and get them to focus on when they're getting the urge, and develop much more of an awareness about their tics. And again, they don't always get that, but we try and work on that. Then with HRT, what we do is we get them to develop what we call a competing response. And that's an action or a movement that you can't do at the same time as the tic. And then within the sessions we practice them doing the competing response instead of the tic. So in terms of the competing response, there are 5 golden rules, and those are: it has to be completely incompatible with the tic, so you absolutely cannot perform the tic at the same time as doing this other movement. It has to be more socially acceptable, because often one of the reasons why young people will want tic treatment is because it's drawing attention to them, and so often we'll want the movement to be smaller and in their eyes more socially acceptable than the tic. It can be done anywhere, that they can do it for longer than a minute, because often the urge itself will last for longer than a minute, so it has to be realistic, and you have to do it without any props at all. So sometimes we say you have to be able to do it naked in a desert, because if you're wanting to use, say, a cup to stop you doing your tic, you might not always have that cup with you. So some examples of competing responses. If you have a sniffing tic, that might be breathing in and out of your mouth without a pause, because you can't sniff while you're doing that. A swearing tic, you might breathe in and out of your nose without a pause while pursing your lips together. Shoulder shrug, we might get them to depress the muscles in their shoulders down instead of up. If you have a hand stretch, you might get them to make a fist instead. And there's all sorts of different ones you can do, and you'd come up with one in collaboration with the client that you're working with, make sure it's acceptable to them, get them to practice it and check that they're able to do it instead of the tic. And then really you're just practicing, so that they're almost learning this new skill of moving in a different way. So you'll get them to feel the urge as it comes on, practice doing the competing response, and hold it for as long as you can until they can't do it anymore, and to try and get them to do it for longer and longer each time. So you're timing them really. And some children get quite excited about this and quite involved, and some children find it quite stressful because it's actually hard to do. Yeah, because it's people say it's the urge that's the irritating thing most often, not necessarily the tic, because it feels so uncomfortable. Yeah, and this is the thing about these treatments, which is important to say and which is important to tell patients as well, is that they only reduce, research is mixed, but they tend to reduce the tics by about 30 to 40%. So, you're not getting rid of them. This isn't about eliminating tics, it's about reducing and controlling. And a lot of the children that we work with, that's what they're saying, is that they're feeling a sense of control, and for them that's really, really important, because they felt like the tics were controlling them before, whereas now they have some control. So exposure response prevention is slightly different to HRT in the sense that you target all the tics at the same time. So rather than picking off each tic and having a different competing response, you work with all of them. And really it's trying to hold the tics in. So it sounds really simple, but it's not, it's really hard. You're just saying to patients, don't do it, just hold it in. And again, it's the same in terms of the content. It's 12 weekly, 1 to 2 hours, psychoeducation, motivation work, tic and urge awareness practice, and then you do lots of practice of holding tics in. So some children might be able to start with suppressing their tics for 2 seconds, but then they work up to 18 seconds, and that's quite empowering. And with the home practice in between, they can do it for longer and longer. So the work's actually quite repetitive, and we try and make it fun by doing it in different ways. Like for example, if they've got a walking tic, we'll get them to walk around and try and hold it in. Because once they've got a bit more skilled at practicing holding it in, we expose them to situations that are likely to trigger their tics. So, for example, if they tick more when they're on the computer games, we'll get them to bring in PlayStation or whatever they have and get them to practice while they're playing. Or we'll get them to imagine being in school assembly. And actually it can be really powerful for some children. It will really bring out a flurry of tics and give them a great opportunity to practice in that challenging situation, which will obviously strengthen their skills. And just very quickly, I'd like us to practice ERP with blinking. It's a tricky one to work with for tics, blinking, because obviously we all have to blink at some point. But I'd just like you to quickly try to, not quite yet, but just keep your eyes open for as long as you can. And again, notice that urge, the tingling, the prickling urge you get, and just try and hold it for as long as you can. So,
That's a hard one.
get your blinks out. Okay, and start now. Some people are amazing at this and can do it for ages, and some people blink after a couple of seconds. Notice the tingling feeling in your eyes. Is it getting stronger? With blinking, it goes up and up and up.
The pollen doesn't help either.
No, the pollen is actually, if you've got allergies, it's going to make it worse. Okay, and relax. It's fine. I don't want to put you through any unnecessary pain. But that's just an example of what of what you would do. Obviously, we don't do that necessarily, but that's how we can demonstrate.
And I suppose to show that the urges, in fact, when we are all holding our not blinking, whatever we're feeling is not even comparable to the discomfort a person with tic feels when you ask them, don't do your tic. So that discomfort is way more than this. It's much more tangible. They have a sensation, and it's like you have a strong itch and you're saying to someone, don't scratch yourself, hold back and see how you feel and how long you can sit with the itch.
Yeah, and imagine if you've got multiple tics and multiple urges going on in your body. It's really hard. Now I'm really aware of the time. We've got 15 minutes left. Just no, that's not. I mean, there's just so much to talk about, isn't there? And now, I just want to say you'll get the slides. There is an evidence base. It's stronger for HRT than ERP, but with ERP it's emerging, and early results indicate that it is a useful strategy, and there's more stuff coming out which is yet to be published.
I would say the reason is HRT's been around a lot longer.
Yes.
It's not that ERP hasn't had good evidence, it's just people are doing it more. And that we've found ERP's really good, particularly with younger kids, because it's a lot simpler. So it's a much easier to say to a little league, just hold, than to try and think of competing responses and things like that.
Because with HRT, often they're holding one tick with a competing response, let's say the neck one, and then all the other ticks are happening loads, and they're doing vocal ticks, and they find that quite irritating. With the ERP, you just say stop all ticks.
Yeah.
So I think although evidence is showing something, but clinically I find ERP.
Yeah, I prefer
And there's some big trials from Denmark coming out.
What do you do when you've got these complex tics? When you start? Which tick do you, how do you break it down?
Well, that's a good point, but that's kind of what you have to do really, and that's the good thing about ERP is that that's the main treatment that's indicated if you've got multiple tics.
Right.
So you would unpick what urges they're feeling in different parts of your body, and you just get them to hold all the tics.
Okay, all at the same time.
Yeah. Often what we sometimes end up saying is don't worry about the blinking, because that's really tricky.
Yeah.
So we'll just say blink away and just try and hold your other ones.
Right.
But sometimes, so if we see someone that comes in with one particular really problematic tic, then we might go for HRT for that.
Yeah.
Especially if it doesn't happen very often, but it's really problematic. So say for example, a punching tic. So someone might be punching walls or punching people or things, but they don't have loads of other bodily tics. And it may only happen once every 20 minutes. It's hopeless doing ERP because you're going to sit there for ages and nothing's happening. But it's much better to do like an HRT in that situation.
Yeah, it's more straightforward. I'm not going to go into the mechanisms of action because these are just hypotheses about how it works, and again you'll get the slides, and actually I suppose the key thing really is that it is helpful but it doesn't eliminate tics, and that the key is practice really. That's really important. They need to practice for about roughly 10 minutes each day, but we do kind of adjust that depending on how severe their tics are, because if they're ticking very frequently, then it can be just exhausting to do that. So we kind of base it on a individual
Can you
basis.
resolve them completely, or is it a bit like stammering that you teach the strategies for it, but you can't.
Good evening. Canada Water Library will be closing in 15 minutes.
Oh.
Please don't forget to take your items with you and take any books and CDs to the self-service shop.
That's a good way to end the
You
session.
can't resolve it completely. It just helps to reduce and control. Yeah, and then you just have to let it take its natural waxing and waning course until hopefully it will wane. The other, just to quickly mention, cognition can be a strong part of it as well, and often I'll say to children when they're really, really struggling to kind of give themselves some self-motivation. I can control this, I can tolerate this urge, I can control my tics, and that just helps them to go a little bit longer. In terms of group delivery, it tends to be one-to-one, but there's some evidence for groups, and I just wanted to point out the Orbit trial, online remote intervention for tics, because if it's not accessible, if these treatments aren't accessible in your area, they're running an online trial at Nottingham University, and you can find out more about it on the Tourette Action website.
You can do it through Skype.
Through Skype, that's right, yeah. There's also a great app called BT Coach, which helps you to do the home practice of ERP and HRT.
Yeah.
And very quickly, when to refer, if the tics are impairing, if the child and family are motivated, and to consider comorbidities. The research doesn't look at it, always excludes complex children with ASD, but actually, anecdotally, I think we find that it can work very well with children with ASD, and it can be trickier with ADHD because there's that impulse control element. But
I think there is some evidence though that if the IQ is, I think it was below, if there's a learning disability and it's below, I think about 60 or something, that probably the behavioural interventions are not going to work.
That said,
it's not a great evidence base, but
no.
But it doesn't mean you can't. I mean, it depends on the child, obviously, that you might have to go for medication.
But many children are naturally doing these things as well, which is interesting.
Yeah.
But often the focus isn't, as although we talk about treatment for tics, that often the psychological interventions that we're doing in our clinic are for anxiety. So we're doing CBT for anxiety, psychoeducation, mindfulness, because a lot of these young people, even though their tics are severe, we recognize it's the anxiety making things worse. So once the anxiety is less, the tics reduce anyway, and it also improves their quality of life much more. So a lot of them don't necessarily require intervention for tics, they require intervention for anxiety and OCD.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.